This was a presentation given by Dr. Joe Veltmann on August 28, 2014, before 250 medical doctors in Guadalajara, Mexico, as part of a seminar entitled Using Genomic Testing to Improve Patient Outcomes. It is a pleasure to be here this evening to share this new and exciting information on BRAC1 and BRAC2 genes and ER-positive breast cancer, and more importantly, how genomic testing and appropriate interpretation of those genomic results can lead to improved patient outcomes. Let me first present the learning objectives for this slide presentation. We're going to differentiate between BRAC1 and BRAC2 breast cancer, which, as all of you know, is the inherited form of this disease, versus ER-positive breast cancer, which is triggered by estrogen or its metabolites. Second, I will discuss the biochemical mechanisms behind each of these diseases, and then springboard into a discussion of how functional genomic testing can be used to individualize treatment strategies for each of these breast type populations. I'll then share with you my clinical experience with a woman diagnosed with ER-positive breast cancer and follow her through her genomic testing, nutrigenomic strategies, and biomarker testing. I'm pleased to report that she is cancer-free more than 10 years post her diagnosis. With all the publicity about Angelina Jolie's recent BRCA1 and BRCA2 diagnosis and her decision to have both a bilateral mastectomy and ovaries removed, you would think that this type of breast cancer is the most prevalent, but it actually only accounts for between 10 and 15% of all breast cancer. A fact that you might have missed in a recent survey of a Toronto hospital showed a twofold increase in the number of women wanting to get screened for BRCA1 and BRCA2 genes during the 6 months after Angelina Jolie's announcement. However, the incidence rate did not significantly increase among the women tested. This illustrates to me the power of celebrity and the media to bring attention to important health issues like breast cancer. As this story illustrates, any publicity about breast cancer can lead to early detection and better patient outcomes. However, I spend a lot of my clinical time educating women about the difference between BRCA1 and BRCA2 breast cancer and ER-positive breast cancer, which may also happen to be in your clinical practices. For the record, ER-positive breast cancer comprises about 75 to 80% of all breast cancer diagnosed in the U.S. To put it in real numbers, more than 200,000 women each year are diagnosed with ER-positive breast cancer, whereas between 14,000 and 19,000 women are diagnosed with BRCA1 and BRCA2 breast cancer. I was interested in knowing how the breast cancer rate and mortality associated with the disease differs for Mexico and other Latin American countries versus the U.S. According to a recent review published in 2013, except for Uruguay, which has a breast cancer rate that even exceeds the U.S., the rate of breast cancer in Mexico and other Latin American countries is significantly less than that found in the U.S. There are a lot of reasons for this, which we don't have time to present in this presentation, but suffice to say, by the year 2030, the number of breast cancer deaths in Latin America will double to 74,000, twice as many as those reported in 2008, simply because the number of women 60 years of age or older will increase twofold. For most of us, we were taught in medical or graduate school that mutations in the BRCA1 and BRCA2 genes resulted in impaired DNA repair, leading to rampant cell division, and therefore these genes had tumor suppressor function. We are finding out other truly amazing things about these genes, which I'll be sharing with you shortly. Nevertheless, the disease is catastrophic to women diagnosed with BRCA1 or BRCA2, because the lifelong risk of breast cancer is greater than 87% and the risk of ovarian cancer is 44%. A BRCA2 diagnosis is much less, with only a 7% lifelong risk of breast cancer and a 25% risk of ovarian cancer. In men, there is a reduced risk of male breast cancer when diagnosed with BRCA1 BRAC1 versus BRAC2. As you might imagine, the cancer risk in the second breast in women is increased in BRCA1 diagnosis. As we know, BRCA1 and BRCA2 genetic mutations are not just limited to either the breast or ovarian tissue, and the penetrance of these genes in women is found in other reproductive tissues like the cervix and uterus, along with the pancreas, colon, stomach, gallbladder, bile duct, and even skin cancer. In men, the profile is very similar. There is a huge spread between the lowest and highest percent risk across both breast and ovarian cancer in BRCA1 and BRCA2 gene carriers. Some of this variation can be explained by the 25 SNPs, or single nucleotide polymorphisms, linked with the risk of developing breast ovarian cancer for BRCA1 or BRCA2 carriers, or as recent evidence shows, other genes involved in the repair of double-strand breaks such as PALBS associated with the homologous recombination and inter-strand cross-link repair pathways. An excellent article appeared in this August 7th issue of the New England Journal of Medicine describing the impact of PALBS mutations on familial breast cancer. One or more SNPs in either of these DNA repair pathways, interstrand cross-link repair, single-strand DNA repair, or homologous recombination, can lead to increased risk of what we typically call BRCA1 and BRCA2 breast cancer. As this graphic clearly illustrates, BRCA1 and BRCA2 breast cancer is much more complex and complicated. Maybe in the near future we will reclassify BRCA1 and BRCA2 breast cancer based on gene mutations in one or more of these DNA repair pathways. As we will see in the next couple of slides, how the BRCA1 and BRCA2 genes trigger either breast or ovarian cancer is dependent on estrogen or its metabolites. In normal functioning cells, BRCA1 and BRCA2 are tumor suppressor genes, whose function is to maintain genomic integrity by repairing double-strand breaks or preserving interstrand cross-links between DNA base pairs in concert with a master signaling regulator called NRF2. NRF2 protects DNA from oxidative stress by enlisting the help of antioxidant genes. You may be familiar with some of these already with your understanding of the antioxidant cascade, genes like glutathione synthetase and reductase. If BRCA1 gene is mutated, it no longer partners with NRF2, leading to massive oxidative stress and cell apoptosis. However, in tissues like the breast and ovary, where estradiol levels or its metabolites are high, estradiol or its metabolites can partially turn on NRF2, keeping these cells alive, accumulating more and more mutations, and ultimately leading to breast or ovarian cancer. This slide shows the interconnection between NRF2 and the 6 different antioxidant pathways, namely production of NADPH, iron sequestration, glutathione utilization, quinone detoxification, glutathione production and regeneration, and TXN production, where TXN stands for thioredoxin, and as the name implies, is involved in cell redox homeostasis. A SNP on one or more of the genes I just mentioned, affiliated with neutralizing free radicals by different antioxidant pathways, can alter the cell's ability to survive, depending on whether the SNP either upregulates or downregulates gene expression, resulting in a greater risk of cancer in estrogen-rich tissues. Those genes I have circled in red are already being evaluated in a gene panel developed by Total Quality Medicine here in Mexico. Having this genetic information may lead to better nutrigenomic strategies to mitigate some of the effects of these gene mutations. More research will be needed, of course, but it shows the potential for individualizing and personalizing treatment strategies unique to a person's DNA map. What is clear is that genetic mutations, not only in the DNA repair pathways, but also in the antioxidant genes linked to NRF2, could contribute to a greater risk of breast or ovarian cancer in women with BRAC1 or BRAC2 mutations. This leads me to my next question. Who needs BRCA1 counseling and genetic testing? If you are a patient, then the criteria is pretty specific depending on the type of cancer, gender, and age as to when it was diagnosed. Breast cancer at age 50 or younger. Ovarian cancer at any age. Male breast cancer at any age. Ashkenazi Jewish descent and has a personal history or family history of ovarian or pancreatic cancer. This would qualify for BRCA1 counseling and genetic testing. If the patient's family is concerned about the penetrance of BRCA1 and BRCA2 in the family gene, then the following criteria can be used. Remember that consulting a medical professional who may or may not refer you to a genetic counselor is also advisable. 2 breast cancers in the same person or in the same side of the family. Family member diagnosed with triple-negative breast cancer at any age. Pancreatic cancer and in breast or ovarian cancer in the same person or on the same side of the family. 3 or more family members with breast cancer on the same side of the family. Or if a family member had been previously identified with BRCA1 or BRCA2 gene mutations. This would also qualify for BRCA1 and BRCA2 gene testing and counseling. The analysis of a woman's DNA to identify whether she is at risk for the BRCA1 or BRCA2 gene form of breast or ovarian cancer started in 1996. The technology was new at the time, and the company, Myriad, patented their technological advances. However, in 2013, the U.S. Supreme Court said, not so fast. A naturally occurring DNA segment is a product of nature and not patent eligible, simply because it has been isolated. As a result, the cost of BRCA1 and BRCA2 gene testing is expected to come down from an average of $3,000 to less than $1,000 as more companies enter the field of BRCA1 and BRCA2 testing. In 2015, TQ Medicine will offer BRCA1 and BRCA2 testing as part of a FEM panel. This will help physicians better serve their patient population because samples will be now sent to Mexico City for analysis rather than the U.S. A diagnosis of BRCA1 or BRCA2 gene mutations offers very little treatment choices. Most women elect to have a bilateral prophylactic mastectomy along with an oophorectomy to remove all tissues that might promote either breast or ovarian cancer. Some women are declining surgery and following a program of persistent surveillance with twice-yearly mammograms, MRIs, and transvaginal ultrasound. The research suggests that pharmacological therapies following surgery can decrease a woman's chance of recurrence. However, physicians need to evaluate a woman's detoxification genes to determine if any of the drugs used, either to block the effects of estrogen like tamoxifen or block the synthesis of estradiol from either testosterone or androstenedione, are under the control of specific cytochrome P450 genes, which can affect drug efficacy. Tamoxifen is a good example of how a SNP on CYP2D6 can alter the biotransformation of the parent drug into its biologically active molecule endoxifen. Therefore, it would be best practices to do a pharmacogenomic test panel on every woman before they are prescribed tamoxifen or any of the aromatase inhibitors. A pharmacogenomic test panel is available through TQ Medicine and Genomic Solutions Now in the United States. Check out the respective websites for more information. This slide highlights the lifestyle, dietary, and pharmacological recommendations for BRCA1 and BRCA2 carriers following surgery. As you can see, they are what I call OSFA, or one size fits all. Each patient is recommended one or more of the following in hope of preventing cancer's recurrence. Unfortunately, surgery does not ensure that the patient is cancer-free, and adjunctive pharmacological therapies are recommended to decrease a woman's exposure to estrogen. Recent in vitro research has demonstrated that estrogen may rescue BRCA1 mutated cells from apoptosis and over time promote more double breaks in cellular DNA, leading to a higher risk for cancer in the breast and ovarian tissue. If you subscribe, the year 2014 is the beginning of the personalized medicine era, then you can appreciate this slide, because instead of the OSFA approach, I have listed genes evaluated as part of a wellness panel offered by 2Q Medicine and Genomic Solutions now, which can individualize recommendations about alcohol use, the type of exercise best suited for each individual, whether that be aerobic, weight training, or a combination of both, how much dietary fat, protein, and carbohydrate would be appropriate to optimize body weight or to promote weight loss, utilization of vitamin D, beta-carotene, green tea, antioxidants including coenzyme Q10, and whether an individual, because of a bitter-tasting gene, is adverse to cruciferous vegetable consumption. I would like to point out that the genes that are in red are those linked to the NRF2 pathway and may have importance in preventing BRCA1 breast and ovarian cancer or its recurrence. A pharmacogenomic panel can also evaluate genes that encode for enzymes in phase 1 detoxification, such as CYP2D6, 3A4, 2C19, 1A2, and 2CA, 2C9. If you're interested in knowing how estrogen molecules are biotransformed, then the estrogen gene test can be very useful. I'll share more information about this test in the second half of this presentation. One last bit of information before we close this section of the presentation that will probably alter the way you think about inherited diseases in the future. We've been taught that genes that pass an inherited disease from one generation to another are fixed. However, research recently published may turn that notion on its head. Women heterozygous for the BRCA1 gene were given 300 milligrams daily of a nutritional supplement called Bioresponse DIM. DIM stands for diindolylmethane, and lecithin is used to improve its absorption. After 4 to 6 weeks, there was a 34% increase in BRCA1 messenger RNA expression. Why is this so important? First, this is the first time that a study has demonstrated an increase in BRCA1 messenger RNA expression using a dietary supplement in vivo. Second, it may give women with a BRCA1 mutation an adjunctive therapy following surgery to prevent the recurrence of this inherited form of breast cancer. We have known for quite some time that DIM can boost protein expression associated with the BRCA1 and BRCA2 genes in vitro, and through its effect on NRF2, protect against reactive oxygen species. Now we may be on the verge of finding specific nutrigenomic strategies to overcome the effects of genes considered fixed and that pass inherited diseases from one generation to another. Here are some prophylactic recommendations for BRCA1, BRCA2 breast cancer patients following surgery. These can be broken down into testing, and here again I'm recommending the estrogen gene test. For those that are interested in ordering this test, you can do so through TQ Medicine. Also, it would be important to do a salivary hormone level test and to follow up to see whether any nutrigenomic interventions need to be tweaked. I typically recommend the urinary estrogen metabolite test. Given the recent research associated with Bioresponse DIM, I would be certainly recommending this dietary supplement, particularly for women that are heterozygous for BRCA1 and BRCA2, and of course to boost antioxidants and anti-inflammatories in that woman's diet. This completes the first section of Dr. Veltmann's presentation to a group of physicians in Guadalajara, Mexico on the 28th of August. Thank you for your attention, and I hope you'll join us for the second half of this presentation.